Our final speaker, he's here already, very prompt, is Professor Ken Ong from Cambridge University. Ken is a professor in Paediatric Epidemiology, and you've written a paper with others on preschool children, high but decreasing prevalence of overweight in preschool children, encouragement for further action. So we've had some action. You're encouraging us to do more.
Thank you very much. Thank you, Cameron, and thank you to John and Andreas for organising an excellent meeting. Just as an introduction, I bring various perspectives to this topic as an epidemiologist, as a hospital-based specialist in childhood obesity, and also as in public health nutrition as a member of the UK Scientific Advisory Committee on nutrition. And childhood obesity is a very broad topic. I'm going to focus on the modern trends and new science. So firstly, in terms of new science, you heard this morning from Nick Timpson, there's been a growing number of genes found to cause obesity. In terms of the monogenic single gene disorders of causes of obesity, almost invariably, these all cause very early onset, rapid weight gain from infancy and excessive appetite. And very thankful to Martin Warbich and Stephanie Zorn, who prepared these plots just yesterday to illustrate from their recently published paper cases who have rare genetic mutations causing antagonistic leptin. And you can see the marked, dramatic increase in their weight or BMI right from birth. And these are characterized by very excessive appetite or hyperphagia. So it's important to recognize that BMI has a very significant heritable component, and this is higher in children than in adults. This is heritability of achieved BMI, and in terms of prospective weight gain or gain in BMI, it's clearly higher in childhood than in adults. In terms of the common genetic variants, again, Nick Timpson also told you that there are hundreds of thousands of adults included in GWAS studies for adult BMI. Unfortunately, the data in children is far less, but the emerging data from cohorts such as ALSPAC or here MOBA show that there's only moderately strong correlation in the genetics of adult or childhood BMI. And in this recent publication, they highlighted a cluster of genetic signals that cause a transient rise in BMI in childhood, and these signals implicate genes that regulate appetite systems such as GLP-1R, leptin receptor. So really important need to focus on children as well as adults. Another perspective for highlighting the importance of childhood obesity is that it causes health problems in children. Far too often, the burden of childhood obesity is measured solely in terms of its tracking into adult life and its impact on chronic diseases in later life. But as you can see here, childhood obesity causes a number of very substantial physical and mental health issues during childhood. So moving on to modern trends. Well, this figure illustrates probably what you've seen in many other types of presentations, with a steadily increasing prevalence of overweight here in young children aged 4 to 5. This is the data collated from the World Health Organization based on observed data from 1990 through to 2010. Then they extrapolated or predicted further increases in these trends up to 2020. But with Sarah Masson and colleagues, we've collated, both reported and some new data to show some significant reductions in the prevalence of childhood overweight in this young age group. Starting from around 2005 to 2010, we see reductions of 15% in New Zealand, 9% in Germany, 5% in the state of Victoria in Australia, and you could argue that 3% in England is more of a plateau than a reduction, but clearly is very different from the predicted rise in these prevalences made by the WHO. And these data fit the proposed fourth and final stage of the obesity transition. These were proposed by Jacks et al. And in this publication, it was very much a hypothesized stage. They said they could found no robust evidence that the prevalences of overweight or obesity are coming down. And we posit that we've found robust evidence, but only in the very youngest children. So, for example, in the UK, in the older age group from the National Child Measurement Programme, we see this ongoing steadily rise in the rate of overweight. And we don't see any evidence of reductions outside of high-income countries. You see, the dots are from data in South Africa. They come from separate surveys using separate survey design. So I haven't joined the dots. Clearly, there's no evidence of reduction. If anything, the prevalence has accelerated far beyond even the predictions of the WHO. So, of course, the obvious question is what's driving these changes? As we heard this morning, we need to show caution in making causal inferences. And unfortunately, it's very challenging to say confidently what is the causal reason for any secular change. But in this age group, there have been many substantial changes, and we argue that the reasons are likely to be multifactorial. So firstly, from the early 2000s, we and others reported primary studies showing associations between faster infant weight gain and higher indices of adiposity in later life. And there are many reviews now showing highly consistent findings across. You can see 45 out of 46 studies reported this positive association between faster weight gain in infancy and higher adiposity in later life. And when our studies were first coming out, the prevailing beliefs, both in families but also health professionals, was that overweight in infants and young children was transient or puppy fat. This evidence has translated into a number of interventions. Baby milk, we targeted and reduced the volume of milk intake in formula-fed infants. Nourish addressed complementary solid feeding. Insight had a broader approach of responsive parenting and responsive feeding. And now there are estimated around 60 either published or ongoing trials for very early obesity prevention. This evidence has reached national government reports. The UK Scientific Advisory Committee on Nutrition highlighted the excess calorie intakes and excess weights of children. These are from national survey data, and also reflected in the food industry. So this and a handful of trials have shown that lower protein composition of formula milk is associated with a lower trajectory of weight, and BMI is from birth to age 5 years, and in the lower protein is in the squares, and that follows the trajectory of breastfed infants, which is the optimal trajectory. And just to reassure some people about, there's no concern about low protein intakes. Protein intakes in UK infants and young children are still 3 times higher than estimated requirements. This plot also, as I say, illustrates the optimal trajectory of weight gain in young children and infants, which is set by breastfed infants. And the World Health Organization emphasized this by producing new growth charts in 2006 based on predominantly or exclusively breastfed infants, which follow this lower trajectory of growth and weight gain. And when you plot the average child in the UK, here's the average child in ALSPAC, plotting them in blue against the World Health Organization growth charts, you can see much more clearly illustrates the excessive weight gain in the typical formula-fed infant. And these charts were implemented in the UK in 2009, so all parents have this in their handheld growth records, and many other countries followed suit soon after that. Beyond, in our paper, we term these changes as structural determinants of healthy weight under the categories of environment, social, policy, and commercial. And even beyond diet and diet-related policies, there are a number of other very relevant changes. And I highlight a couple here. One is we see very significant reductions in the prevalence of maternal smoking in many of these settings. And of course, this may be associational. Smoking may be associated with other unhealthy lifestyles and diets, But smoking in pregnancy does have a causal effect, biological effect on restraining fetal growth. They have lower birth weight, and these infants come out and they catch up very rapidly in infancy and often show higher adiposity and BMI. As well as smoking, across all of these settings, have seen very substantial changes in state-sponsored early childhood education and childcare. And you can see a number of interventions provided by governments, and gradually with increasing implementation over the 2000s. And I think as important as the provision of this care is the promotion or the development of guidance and implementation of the guidance to promote healthy food and physical activity settings in these early education and childcare settings. Of course, it's difficult to evaluate such policies, but we know from COVID, and we only have data here from the National Child Measurement Programme in England, and I know there were many changes during COVID restrictions, but one of the most marked for families was the closure of early childhood education and childcare settings, and the prevalences of overweight came down straight after that. So I've got a couple more slides after this, but to summarize, these recent trends are encouraging. I think for many people who don't work in childhood obesity, or indeed for many people who do, people find this a sort of an attitude of despondency, that when new policies, interventions are suggested, there's sort of pessimism that that's not enough. They see just rising rates of overweight and obesity and really think nothing is going to change. But our data shows that these steady rises in overweight are not inevitable. Of course, the reasons are likely to be multifactorial and cover a wide area of diet and related and wider policies. And the efforts need to be maintained. And the jump in prevalence during COVID really gives an important warning for that. And they need to be strengthened. These are still at very high levels. And we need to make sure that all families benefit. So although the rates of overweight have come down steadily in the young children in England, amongst the most deprived households, the rates have continued to increase. And in fact, this deprivation gap has steadily increased and was particularly marked during that COVID period. We also have to recognize and empathize that many families have to work a lot harder. There may be a susceptible risk of overweight. And it's not just a matter of genetics versus environment. This paper nicely shows that these factors exacerbate each other. So the heritability of BMI in very young children was substantially higher in those living in obesogenic environments. So the impact of genetic factors is clearly exacerbated by an obesogenic environment. So we need to make sure that these changes are maintained and indeed strengthened, and we need to make sure that all families benefit. We need more evidence about the determinants in low and middle income countries, where the determinants may be quite different beliefs and cultural attitudes to weight gain and nutrition. We need to make sure that that interventions don't disadvantage deprived groups, and we may need to tailor interventions to those families with families at higher susceptibility of overweight, often manifested by more hungry children or with lower satiety. Just to acknowledge my co-authors on this paper, and thank you for your attention.
One question before we move into the panel discussion. I mean, you showed the UK data and a selection of international data. How generalizable is that? I mean, for example, that isn't the trend in the US, is it?
No, it isn't. The NHANES data don't show that. They did show a plateau at some stage, and then that seems to have gone up again. It's important to note that to see these trends, one does need robust data, accurate data, using similar survey designs across the studies, and that is challenging to derive. But you're right, I think I highlight these to show that it's possible. Mm-hmm.